Okay. Welcome for those of you that are arriving. I'm just going to wait 1 minute just to allow a few more people to come into the room, and then we will get started. Scaling up hepatitis B birth dose. Okay, so the numbers are slowing down a bit. So I'm actually going to start just by welcoming you to another one of our series of Let's Break It Down, scaling up hepatitis B birth dose. My name is Rachel Halford, and I'm the president of the World Hepatitis Alliance. Thank you for joining us today. For those of you that are familiar with our websites, our webinars, we have, as usual, simultaneous translation into Spanish and French. If you just pop to the bottom of the screen, you'll see there is an interpretation button. There it is. Press that and choose the language that you would like to listen to the webinar in. There is also the option to pop in questions. There's a Q&A box there. And then we do have time after our presenters today for some questions where you'll be able to put your hand up and then we can turn your mic on. The one thing I just asked, though, is because of the translation, if you could speak slowly, as we're asking all our presenters to, just to make sure the translators can translate clearly for you. I don't think there's anything else there. I just to say it's such an important webinar that we have today. The hepatitis B birth dose vaccine is a critical part of the programme to prevent mother-to-child transmission of hepatitis B. And I'm delighted today because we have some incredible speakers that are here with us today. I'm just going to check and see if our first speaker is here, Gloria. Is Gloria here today?
She's not joined yet.
She's not joined yet. Okay, so what we're going to do is, first of all, we were going to have Gloria, who's was going to share some of her lived experience. But actually, I'm going to start with Funmi. Thank you so much, Funmi, for coming in a little bit earlier. So we've got Professor Funmi Lesi from the WHO hepatitis team. And Fumi's going to talk a little bit about the role of hepatitis B birth dose vaccine in accelerating hepatitis elimination. So over to you, Funmi.
Thank you very much, Rachel. And it's such a pleasure to be here representing WHO. And you're quite right, hepatitis B birth dose is very important. So we do know that hepatitis B infection remains a global public health challenge that affects over 240 million people worldwide. So what I can do is really set the scene for the oncoming discussions from the person with lived experience, from Gavi, and from the other countries. So of these 240 million people, the distribution is kind of variable regional distribution, and 85% of hepatitis B occurs in 3 world regions, pretty much sub-Saharan Africa, where 44 of 47 countries have the general population prevalence for hepatitis B exceeding 2%. And the second big region is the Western Pacific region that is really dominated by China, and the Southeast Asia region dominated by India and Indonesia. So mother-to-child transmission accounts for a significant proportion of chronic infection. And I'm making it is not really sexual transmission as commonly thought by many. Now, in 2022, there were 1.3 million cases of new hepatitis B infections, or if we put it in smaller words, 140 every hour. In fact, 2 people are born with hepatitis B infection every 2 minutes with transmission. So there is an urgency. Of all 5 new cases of chronic hepatitis B, 3 are from Africa, and the 4th is from Sierra, and the 5th is from various other regions. And we do know that infants infected at birth have a 90% chance of developing chronic infection, leading to long-term complications such as liver cirrhosis and hepatocellular cancer. And to put this in perspective, it takes about 20 to 30 years to develop advanced disease and cancer, which means that the child that is infected at birth may have the liver cancer at age 25, 30, or 40 years. So preventing new infections is a primary strategy for liver cancer prevention. Now, we have a global strategy for hepatitis elimination, which has ambitious goals and targets. And it calls for 95% reduction in new hepatitis B infections, as well as reduction in mortality by 65% by 2030 using a 2025 baseline. So WHO provides guidance for the major interventions. So for PMTCT of hepatitis B, our guidance are produced by the department that guide immunization as well as the hepatitis team. There are 4 major interventions. These are the hepatitis B birth dose that is administered within 24 hours of birth to all newborns, regardless of maternal hepatitis B status, which is the topic of our discussion today, as well as the childhood vaccination series, which is given at 6 weeks, depending on the country profile for vaccination, but usually is 3 vaccines that end at 6 months or thereabout. These are the backbone for prevention of hepatitis B PMTCT. But I would also mention that newer interventions such as the maternal antenatal testing and maternal prophylaxis are complementary actions to strengthen vaccination and bridge the gaps. There's also the role of immunoglobulin in some countries, but I would not go into that. So where are we today? The global coverage of birth dose remains low at 43%, and it is far short of the 70% target for 2025. It is even worse in the Africa region, where it is 17%. So paradoxically, the region with the highest prevalence, with the highest births, has the lowest coverage of hepatitis B birth dose. As of this year, 2025, over 145 countries have implemented either universal or targeted hepatitis B birth dose vaccinations. And there are lessons that have been learned, including the need to strengthen and coordinate health systems to ensure delivery within 24 hours. We have to discuss the commodities, the vaccines, and even the system of delivery, integrated delivery systems, including task sharing, including efficiencies across programs, managing home deliveries, which I'm sure we'll come across today, and data systems. One of the promising approaches is integration and triple elimination, which I know will be discussed in later webinars. So the scale-up of hepatitis B birth dose is critical to hepatitis B elimination and liver cancer prevention. I think I'll stop here, and I just hope that I've stirred up further interest in hepatitis B birth dose and set the scene for this discussion. Thank you very much, and over to you, Rachel.
Thank you, Funmi. I think you set the scene absolutely brilliantly. The data is quite shocking, actually, really shocking. But I've just seen that Gloria has arrived, which is brilliant, because I think that Gloria is a woman who has lived experience of hepatitis B, and I think this will marry really well in setting the scene with everything that Funmi's just spoken about. So, Gloria, are you here?
Yes, Rachel, good afternoon.
Hi, Gloria. So I'm going to hand over to you to talk a little bit about why scaling up dose vaccination will be transformative for women living with hepatitis B. Welcome. I'm so glad you could join us.
Thank you so much, Rachel. I'm grateful for the opportunity. Thank you to all the organizers of this webinar for giving me the opportunity to tell my story and contribute to hepatitis B birth dose vaccine scale-up. So maybe I should start with my story. Can everyone hear me?
Oh, you just dropped out for a minute there, Gloria.
Oh, my apologies for that. So since you can hear me, I said I'd like to start with my story. I was first diagnosed with hepatitis B in 2009 as a student. It was traumatizing and difficult for me to come to terms with. I didn't have a good source of information where I could learn more about hepatitis B, how to take care of myself, and what will happen next. So it took time before I get to know more about hepatitis, how it was going to impact marriage, childbirth, and all of that. Finally, I got married in 2016, and I went for antenatal clinics. I was told that I needed to do some investigations to know whether I was eligible for treatment for hepatitis B. So I did those investigations and they advised against treatment. So I gave birth to my first son in 2017 November, and he had the birth dose vaccine within 15 hours, and he had all subsequent doses at the appropriate time. Then I gave birth to my second baby in 2020 during the height of the COVID. And because of the lockdowns and all of that, hepatitis B vaccine supply was cut in my area, Taraba State of Nigeria. And my baby was also sick on admission. So he got his first dose 3 weeks after birth. So for all of that time until he was tested, I was worried. I was always anxious, thinking my baby was going to get hepatitis B. And then it was after everything, after some time, after taking the 3 doses, he was tested and confirmed hepatitis B negative. So I have 2 children who are living without hepatitis, even though they were born by a mother who has hepatitis herself. And I could say that the barriers to hepatitis B birth dose vaccine in my country include non-facility delivery among women in rural areas, and even some that are not in rural areas, but there are cultural practices that support non-facility delivery among them. Then we also have the problem of stock outs, like my baby experienced during the lockdowns, inadequate cold chain storage, funding constraints, and lack of awareness and knowledge. We also have the problem of persons giving birth clinics where hepatitis B vaccines are not available. So it takes more days for thing. What I would say, hepatitis B vaccine, birth dose vaccine coverage in Nigeria here, address the cultural practices that support home-based deliveries are and suburban communities. So we have first child of the family has to be born at home in the village where the grandparents live. We have people that believe that the children should be born at home unless there is a complication. And then there are people also that live far away from the hospital. So giving birth at home is a norm for them. And before the child gets the vaccine, it takes days or weeks. We also need to increase awareness of hepatitis itself and the importance of vaccines, the availability of vaccines, the importance of those vaccines, and especially the birth dose vaccines. We need to strengthen cold chain infrastructure by prioritizing sustainable energy in rural communities and other places where we don't have sustainable energy. We also need to make vaccines available in private facilities. I don't really know how this has to work, but I know they have complaints that they cannot manage the vaccine cold chain requirements, and then they are unable to get the vaccine on demand when a patient gives birth in their center. We need to strengthen birth notification systems so that these people can be reached with vaccines, maybe by connecting them to centers or by taking the vaccines to them within 24 hours of birth. And there should be a way we engage traditional birth attendants in the drive for hepatitis B scale-up, hepatitis B birth dose vaccine scale-up. Then we should prepare better. The WHO is co-organizing this, and I feel that WHO can help our countries and health systems to prepare better for emergencies and pandemics. My son was born during the pandemic, and that is how dose of the hepatitis B vaccine was delayed for 3 weeks. No child deserves to experience that. No mother deserves to go through the anxiety I experienced within that period, waiting to know my child's hepatitis B status because he was an exposed infant and he had no vaccine within the first 3 weeks of life. I think we can do these things so that hepatitis B coverage, hepatitis B birth dose vaccine coverage will be scaled up in Nigeria, my country, in other African countries, and in other countries that are continuing to lag behind. Thank you very much.
Gloria, as ever, absolutely such a powerful message, such an incredible message. I know you have to go very soon. Do you have 5 minutes, or are you shooting off straight away because you've got to go back to work, haven't you?
I should be able to stay for like 10 minutes more.
Okay, I just wondered, we've got if there's any questions that anybody would quickly like to put in the Q&A. Sorry, we didn't know Gloria's going to go, but just in case somebody's going to put, just while we wait for that, I just wanted to ask you maybe, because I know you run an organisation as well, the Rosa Development Initiative. I just wondered whether you wanted to say something quickly about the work that you do there, perhaps like you were talking about in raising awareness.
Okay, thank you very much for the opportunity to talk about this. At our organization, Rosa Development Initiative, we try to address cultural, human rights, and social issues that impact hepatitis B birth dose vaccine is one of the things we create awareness about. So we talk to people in communities, women in the market, people, worshippers in places of worship, students in schools, and young women who are likely to be having children either now or in the future about hepatitis B birth dose and hepatitis itself generally. So we try to create awareness, and we partner with organizations who are able to carry out testing. So we will create awareness among key populations like young people, adolescents and young women, among women in healthcare facilities attending antenatal clinics and stuff. We try to get them tested for hepatitis, and those who are tested negative, we link them up for vaccination. And for those who get tested who test positive, we try to link them to further testing for confirmation and treatment if they are eligible.
Fantastic. I'm not sure how you do it all, Gloria. You just do so much, but thank you so much. We have one hand raised in the chat. We just take 5 minutes, just 2 minutes, Gloria, just so that the question can be asked. Dr. Simon Onyenka.
Yeah, well, good afternoon, everyone. I'm also speaking from Plateau State, Nigeria. I just want to add up to what Gloria said. Yes, everything she said is correct, because I just, early this year, carried out research on bed dose in Plateau State. And I discovered that there's about 60% of women born at home and private hospitals. And these people doesn't have a vaccine. I also conducted a kind of check in a private hospital to know if actually they have vaccines, but they don't. And again, most of the PHCs, they have a particular day in a week that they normally do immunization. So if any child is born outside that day, he will not receive vaccine or immunization till the day of immunization. So the thing has been a very big problem in this country. I don't know any part of African country that are also experiencing this, but in Nigeria, it's a very big problem. It's a very big problem. I just want to add up to what Gloria just said. Thank you very much.
Thank you very much. And Gloria, I know you're going to have to go. So I want to say thank you very much ahead of you leaving, just for taking the time out and highlighting, exactly how it is for with the lived experience of living with hepatitis B and the impact as a mother, particularly, when you're having children. Yeah, absolutely. Just brilliant. Thank you. I'm going to move on now, though. I'm going to move on because we have Dr. Michael Besong, who will be sharing an update about Gavi's hepatitis B dose vaccine program. So we're delighted to have you with us. So I'm going to hand over to you. Thank you, Michael.
Thank you, Rachel. Thank you for having me on this webinar. I am Dr. Michael Besong. I work for Gavi and I manage the Gavi hepatitis B birth dose program. And it's my pleasure to speak in this webinar and to provide an update on what Gavi has been doing in this space so far to improve or to bridge the gap in access to hepatitis B vaccination in countries that need the vaccine the most. Next slide. So I'll just provide a brief background. So as we may all be aware, the Gavi board had approved the investment case for hepatitis B bird dose vaccination to be introduced in the portfolio of Gavi's vaccines to be supported. That was back in 2018. And this program was due to start implementation in 2021, but unfortunately, COVID hit, and the operationalization of the hepatitis B bird dose program was delayed till 2023, when Gavi board approved that the resumption of the design and the launch of the bird dose program, and the program was actually launched on July, I think July 15 in 2024. Which opened the window for eligible countries to apply to Gavi for support to introduce this vaccine in the immunization program and to support the rollout of the program of the vaccine nationwide in their countries. And just to note that Gavi has been supporting hepatitis B vaccination through the pentavalent vaccine since the year 2000. And by 2023, over 661 million children had been vaccinated with Gavi support. So this is for the time points at 6, 10, and 14 weeks. And additionally, this new bird dose program gives the opportunity to introduce the hepatitis B vaccine at the time point at birth because of the unique advantages that this time point presents as shown by WHO evidence. Next slide. So just as a brief overview, the Gavi hepatitis B bird dose program builds on WHO's recommendation that all infants, including low birth weight and premature infants, should receive their first dose of hepatitis B vaccine as soon as possible after birth, or ideally within 24 hours. And the support available, so Gavi support includes procurement of the vaccine. So for eligible countries, Gavi actually pays for the procurement of these vaccines and associated supplies, provides a cash grants, which is vaccine introduction grants to fund activities related to the introduction of the vaccine, like training, updating hospital records, and so on, as well as technical assistance to support countries in actually preparing the request to Gavi. And overall, in terms of eligibility, Gavi eligible the countries that are eligible for Gavi hepatitis B bird dose support must first be Gavi eligible countries, and these should be countries that have not yet introduced, or countries that had not yet introduced the hepatitis B bird dose vaccine, as well as a few countries that had introduced the vaccine after the Gavi 2018 board approval, but had introduced it in a small scale. So these few countries like Ethiopia, Rwanda, and Uganda were exceptionally allowed to also access the full available support for hepatitis B bird dose to scale the vaccine nationwide. So in terms of eligibility, all Gavi countries that have not yet introduced the vaccine or that had introduced after 2018 in a small scale can apply for support. And lastly, in terms of consideration, Gavi is keen to seeing that when countries are thinking of applying for support and are preparing their introduction plan, they need to see the element of strengthened coordination and integration with maternal, newborn, and childhood and other programs, given that this is a new time point, and as well as strengthening community health systems to enhance access and uptake. So given that the vaccine must be given within 24 hours, it will likely be given in delivery rooms, and there is actually need for coordination with all these services to ensure the timely delivery of the vaccine. Next slide. So just to give us a status of where we are in terms of countries that have already come forward to Gavi with a request to introduce hepatitis B bird dose. So as I mentioned earlier, so currently there are 54 countries that are Gavi eligible. I mean, countries that are eligible for the various types of Gavi support. And out of these, 34 had not yet introduced the hepatitis B bird dose or had introduced it, but in a small scale. So these are the countries listed here, and these 34 countries are all eligible to apply to Gavi for support to introduce the hepatitis B bird dose vaccine. So as you would see here, most of these countries are found in sub-Saharan Africa, highlighting the comment made by Funmi about where the burden lies most is where less vaccination is taking place. And it's really a call for concern. And out of these 34 countries that are eligible for hepatitis B bird dose support through Gavi, 12 have actually already applied to Gavi between when the program was launched in July 2024 to date. 12 countries have applied and have been approved for support. So these are the countries listed here with so these are the 12 countries, and it is expected that the first countries that will be introducing the hepatitis B bird dose with Gavi support will do so as from Q3 2025 going into Q1 2026. So for these countries highlighted here on my slide, the applications have been approved. Their decision letters, Gavi decision letter to the country, which is like the legal framework, has already been issued to the country, and preparations are underway for vaccine shipments to the country and other preparatory activities. So I think this will be the highlight of the program when we see these initial countries introducing, and other countries will follow suit. So all these countries have been approved and will be introducing in the months ahead. Next slide. So I'd like to mention a bit about how countries have previously accessed Gavi support or applied to Gavi, and a shift which will be applied going forward. So sometime back in March, SAGE, the Strategic Advisory Group of Experts on Immunization, urged countries to consider prioritization of future new vaccine introductions, emphasizing that each country should be empowered to make its own decisions regarding prioritization of vaccine introductions and the timing and sequencing of these new introductions. And these decisions should be guided by a systematic country-led process that reflects the local context, and the recommendations should be aligned and integrated into the priorities outlined in the National Immunization Strategy. So previously, countries could apply to Gavi either as a standalone application or as part of a full portfolio planning. And most of the countries that have been approved came through a standalone application. However, Gavi is currently developing a new approach with its new strategy, which will start January next year, of having all countries develop a holistic multi-year application based on the country's national immunization strategy. And this is also to building on the SAGE guidance on countries having a holistic planning and looking broadly at the immunization program and the vaccines that they think they'll be introducing in a period of 5 years, and doing a holistic planning, factoring in all what needs to be factored in, and seeing where synergies can be leveraged. And this Gavi approach will be published by the end of the year and will be used in the Gavi 6.0 strategic period starting in January. And this approach intends to foster more integrated and sustainable immunization programs, given the increasing number of vaccines available and the growing complexity of countries' decision making. And with this shift in how Gavi will be operating going forward, what are the implications for the hepatitis B bird dose community? It means that previously countries will not be coming forth again with single applications for hepatitis B, but will have to do a holistic planning, factoring in other priorities, that's other vaccines that they might want to introduce, and then decide what is most important for their context, and then do a holistic planning. So in terms of these hepatitis B bird dose, stakeholders will need to be trained or get themselves trained on vaccine prioritization and product optimization, including through WHO-led webinars. They will need to participate in country-level discussions on vaccine prioritization and country holistic planning to also provide the evidence and make the case on why the vaccine has to be prioritized, and as well as engage with national bodies like NITAGs to ensure that hepatitis B birth dose is considered alongside other vaccines. Okay, next slide. And just to end, in addition to the Gavi program, Gavi also commissioned a learning agenda sometime last year to study models of delivering hepatitis B birth dose in Africa out of health facilities. So actually this, as our colleague with lived experience mentioned, there are really challenges with administering the vaccine, especially in contexts where children are born outside health facilities. And this study aims to explore innovative delivery strategies, assessing the role of community health systems and understanding stakeholder perspectives, with the primary objectives being identifying promising models of increasing hepatitis B birth dose coverage and disseminating this evidence and learnings for global and country level advocacy. So this study is underway, being implemented by PATH in 4 countries: Ethiopia, Uganda, the Gambia, and Nigeria. And we are expecting early results from this study by the end of the year, which will inform how the vaccine is being delivered, service delivery of hepatitis B birth dose in various settings. So in a nutshell, this is what I can say about the Gavi program so far, and I'm happy to take a few questions if there are any. Thank you very much, and over to you, Rachel.
Thank you so much, Michael. I think we could probably hold a whole webinar on the new your new strategic plan, which you're bringing in next year, the different ways of applying and the changes that are coming, and how exciting to have this pilot program to see how it's going to run in the community. Are you okay to hold on? We're going to do a couple more presentations and then we'll do questions after. Fantastic, thank you, because I'm sure there's going to be an awful lot of questions for you. So thank you, and I'm going to hand over now to Doreen Ruth Akuno, Senior Nursing Officer and Viral Hepatitis Focal Point for the Department of NCD Program under UNEPI. Are you here, Doreen? I'm pretty sure you are now. And Doreen is going to speak to us about Uganda's progress in scaling up hepatitis B vaccination.
Oh,
welcome. Thank you.
Thank you so much. That's my name. Sorry for the late joining. We are at the triple elimination program in the conference in Uganda. So a lot of coinciding activity. Straight to point, can I have the next slide? So the government of Uganda has recognized viral hepatitis as a key public health challenge since 2015, leading to a significant program in addressing it. You forgive me of my background. It's a little noisy, but I have nowhere else to sit. So we have we have progressed, and you see since 2002, hepatitis B vaccine antigen was introduced into the routine, that is the pentavalent, introduced into the immunization program, and that was already done. Then after immediately we did that, the hepatitis B vaccine for adult was also launched in the program, where we were looking at people who were born before 2002. And these adults would come for a test. If you're negative, we vaccinate you. This has been done in a phased manner throughout the country. We started looking at the high prevalence area that is in the northern part of the country, and we cascaded to the western part of the region that only had 0.5%, 0.1%. But we had 4.2% in the northern part of Uganda, spreading across the region. So we started with the high prevalence, and then we scaled down to the low prevalence area. Then in May 2019, hepatitis B vaccine and hepatitis B virus and hepatitis C virus guideline program was launched by the Ministry of Health under mother-to-child transmission control component that came in under HIV department and MCH. So this program was launched, and interventions to eliminate mother-to-child started right away in May 2019. Then in 2019, in September, immediately after that launch, this program was also launched, and that is now the hepatitis B virus mother-to-child transmission. When we launched the hepatitis B mother-to-child transmission, we now integrated kind of this program into the antenatal bit of the HIV, the HIV department. We started working together. And then in February 2022, the triple elimination program came up as a program. Why? Because we were looking at bringing hepatitis disease together with HIV and syphilis. So all this strategy came together to have the three diseases eliminated in the program. Then in October 2022, the hepatitis birth dose was introduced into the routine vaccine. And that is why when you saw Gavi present to us saying that we had a mini introduction, for Uganda, we actually had the monovalent vaccine, which was for the adult. So when WHO brought this birth dose into the guidelines, we had vaccines in the country. And that is when we started vaccinating the babies with the monovalent vaccine as a birth dose, as we were thinking of what else to do. So in 2024 July, we had the National Strategic Plan for Hepatitis, the National Viral Hepatitis Strategic Plan that we were working on. And so when we had worked on this document, we had to launch it. Why did we launch it? We were already planning that as we enter into 2025, we shall have the plan of applying to Gavi to have the birth dose. So we did this, and then in 2025 June, we had the HCV training services integration starting immediately. As we were looking for, we were zeroing on hepatitis B. We felt that even hepatitis C should come in gradually, because we have a few people on board with hepatitis C. So policy and strategic planning was done. Uganda expansion of viral hepatitis services reflects a phased approach enabled by the global normative guidelines and political commitment by our government, and growing technical capacity of all the health workers and all the people that support in the health sector. This has supported steadily integration of policy and intervention across the system. Next slide. So yes, the fact that we feel we are progressing, there have still been some significant interventions for the prevention that we were doing at UNEPI, and then the treatment of viral hepatitis, especially B and C, which are chronic. But that does not mean that we are not looking at other species of hepatitis. But for Uganda, the focus is on the chronic B and C. So for infant, we already looked at the pentavalent that was introduced in 2022. And this is doing well under the Department of Vaccines and Immunization. Then for the adult, we are now doing testing, vaccination, and treat. For the vaccination, we are screening the adults, and then the adults who are not positive, looking at their age bracket. If they miss to get the pentavalent, then that is when we go ahead to vaccinate you. And then looking at also other cadres that really need these vaccines that were not vaccinated. Those are now the targeted vaccination that we are doing as a country. But for all those who test positive, especially for the pregnant mothers, we have to link them to care. That is under the triple elimination. And then for the males that test positive, we also link them to care. And as you see, the free hepatitis B testing program has been there for us. We don't pay. All our government facilities and even private not-for-profit do the screening, and which is free. So over 4 million people have been screened to date, and then over 30% of the infected individuals are aware of their status, especially the adults, and then access to treatment services, including free medications. We have the medications and we are using TAF in the treatment for both the pregnant mothers and then for the general public, that is the male and other non-pregnant women. So we integrated hepatitis B virus prevention of mother-to-child services, like I told you, in MCH department, mother to MCH department, and Uganda is integrating, like now we have the triple elimination, these services into the routine antenatal care. So as part of a combination of intervention to eliminate both the three diseases from mother to child, we all know that most of our chronic clients got this infection through mother-to-child transmission. Studies have shown that. And so we are trying to target the mothers at the antenatal. And that is why the Conference of Triple Elimination is speaking towards prevention of mother-to-child, because this is the same mother that we need HIV, we need to treat for HIV, we need to treat for syphilis, we need to treat for hepatitis. And so we need to embrace the triple elimination program that is coming in. Then we have the safe injection and transfusion services. Of course, I know all the countries really do safe blood transfusion that cuts across every country. And then we have the single use of needle and safe injection practices in all our health facilities. Then when we do that, we know that we cannot reuse these sharps in the facilities, and therefore we also try to eliminate hepatitis through the safe injections in facilities. Next slide. So we nevertheless, we have gone ahead to make sure that we have behavioral change and make community aware of what is happening under hepatitis. So you find that in the Department of Health Promotion, they have done strengthening on prevention of viral hepatitis at the community level in collaboration with panellists and CSOs that we have in countries. Most of our CSOs deal with people who are positive, and they really have experience towards what they have gone through. So they are able to speak to the community, and the community look at them as people who have overcome hepatitis. So they are really very supportive, and we want to appreciate them all the time we give a speech like this. And this include also total sanitation and unwashed programs that really support us in the prevention of other hepatitis species like hepatitis A and E. So under surveillance, we have the National Seroprevalence Surveys by UFIA, that is in 2026, 2022, 2002, then integration of hepatitis indicators into the health management information system, and then we have leveraging routine data into monitoring program and progress on vaccination, testing and treatment, as well as deaths are recorded and we can monitor. Then partners and collaboration, yes, we have technical and financial support mentioned from the partners you're seeing. We have UNICEF, WHO, PEPFAR, Global Fund, Gavi, CHAI, PATH. We already heard about Gavi giving us studies on the birth dose for babies born without the facilities. We are aware of this, and some of us are part of this at the Ministry of Health. The studies have started for Uganda. And then sustained collaboration helps scale up the system and services in the country. Next slide. And I think that is my last slide. Yes, so lessons learned in hepatitis B program implementation, we had progress in hepatitis B virus, prevention of mother to child. We have some key lessons here. We have seen the progress since 2019. There has been a gradual increase across hepatitis B, prevention of mother to child services across the continuum care. So financing, yes, it has always been a challenge, but we want to thank God that Gavi has come in to support on the vaccines, whereas there are still other commodities that needs to be worked on, like the medicines and other commodities. So we have leadership and governance. We really have a strong political leadership, and which is really making our work easy. Before we got any funding for the vaccines, it was just the domestic funding that we used to use both for vaccines and commodities. But now we applaud Gavi that we are having the vaccines in country soon or later. And I think by today we may have that first consignment of the birth dose coming in by Gavi. We want to thank Gavi so much. Service delivery, we have integrated programs. HIV is coming up, syphilis and hepatitis to work together so that we can have the triple elimination. Our current guidance starts with the TAF prophylaxis at 28 weeks, and it has been a challenge because we still have issues on these medications. Sometimes we don't have them in time, and this may lead to mothers getting out. We are losing them at other points, but this is work being done. We know that we shall stabilize on that. Information system, current data capture platform do not provide patient level data to track the care cascaded effectively. I have talked about this already because we cannot track our mothers and really see that even after giving birth, when we start them on prophylaxis of TAF, when they give birth to these babies, are these babies negative? Do we have a system that looks for them? Did they take their drugs well? Those are some of the systems that we need to improve on so that we can monitor the effectiveness of the birth dose together with the effectiveness of the pentavalent together with the effectiveness of the TAF that we are giving to the positive mothers. This comes to the communities that have been talking about stockouts has been issues, and it is affecting patients' care. Adult hepatitis B vaccines are being used in short term, waiting for Gavi. Yes, we are yet waiting for Gavi, and I'm sure about Gavi. There's no more waiting. Sooner or later, we shall have this. I'm very proud of Gavi. I think this is my last slide. Oh, thank you so much.
Thank you, Doreen, so much. I'm really just brilliant, a fantastic example of best practice. I'm conscious of how much time we don't have left, so I'm going to move us swiftly on to Rwanda's progress in scaling up hepatitis B birth dose vaccination. We've got Hassan Sibomana, who's from the director of EPI Rwanda Biomedical Center. So I'm going to hand over to you, Hassan, and just bear in mind that we only have, if you could stick to the 7 minutes, that would be amazing. We might have a chance for a few questions. If not, maybe run over slightly from the session. Over to you, Hassan.
Yeah, thank you, Rachel. I'll be very brief. So thank you a lot for giving me this opportunity actually to present on behalf of Rwanda team how we actually scaling up actually hepatitis B backdoors in a routine vaccination. My name is Hassan Sibomana. I'm the EPA manager for Rwanda, and I have been serving Minister of Health as EPA manager for last 10 years. So for hepatitis B backdoors, so in Rwanda, we don't have actually a universal vaccination coverage hepatitis B backdoors. So what we have as hepatitis B, it is just the 3 doses we are providing at the 6, 10, and 14 weeks in routine vaccines. And we have been providing this vaccine for the last 2 decades because actually the vaccine was introduced in 2002. And today, vaccination rate actually is very high because actually today 96% of our children are fully vaccinated. And I can say that actually among the drivers of this success, there is also a very high coverage of antenatal care attendance and the high delivery in health facilities. Actually, the delivery in health facilities actually is also more than 95% today, which is a very good opportunity for us actually even to succeed with hepatitis B backdoors. And despite this achievement, hepatitis B backdoors vaccine delayed to be introduced in routine vaccination because actually before COVID, we started to think about introducing hepatitis B backdoors. But because of COVID, actually it was not possible. It has been delayed. And let alone actually when actually the pandemic stopped. So we had the chance of introducing hepatitis B backdoors. But at this same time, actually, it was a targeted introduction where actually we're targeting actually pregnant mothers. And we have been able to introduce screening in antenatal care. And then from there, we have been able actually to target also exposed to children to be vaccinated. So with support from CHAI, Clinton Health Access Initiative, so we have been able actually to introduce hepatitis B backdoors for this targeted approach. So we have been able also to update our guidelines and also to update our data systems so that we can also capture individual data. So this is very important because actually today we think that actually in near future shall be able also to continue actually following up even those children vaccinated so that it can be easier also to document actually what we have achieved with hepatitis B, but those introduction, most specifically for those children born from infected mothers. So as achievement, as of today, every facility in the country can provide the hepatitis B backdose. And also we are very happy that actually at least 99% of eligible children, babies have been able to be vaccinated within 24 hours. So meaning that actually it is possible actually to achieve even this milestone of vaccinating these babies very, very early. So for us, we think that actually when we are going to introduce also hepatitis B backdose for routine, a systematic approach to vaccinate all of them, so it would be possible actually to meet also this target of vaccinating children within 24 hours. And also I can say that actually we are capturing data at real time because we're using actually a digital systems. Now our vaccination program is fully digitalized. So meaning that actually also the system of capturing individual data is very helpful. It will be, we shall be able actually to have very good data and documentation because we are expecting also to publish so many papers on hepatitis B, but then once actually are done with introduction, because we had the chance of having also the support from Gavi. So as you have seen from Dr. Michael's presentation, so you have seen that actually we are introducing hepatitis B, but those universal vaccination was actually in Q1 2026. So currently we are in preparations. We are upgrading our cold chain equipment in hospitals because actually a vaccination program was not really being done in hospitals. We have been targeting only small health facilities actually to make sure that actually vaccination program is very good, very well decentralized. But currently with hepatitis B, but those, because you know there is a very big number of newborns actually in hospitals also, we are also introducing vaccination actually in hospitals. And again, we are mobilizing additional funding so that also we can provide these maternity wards in hospitals with laptop so that it can be easier so to capture data. And at the demand side, we are trying our best to make sure that actually we can sensitize our population, because actually that is where we think that we can have issues, because as a new vaccine to be introduced, in addition to 13 antigens we're having in routine vaccination, so we need really to focus on community sensitization. This is what also we are doing today. And we think that actually by January next year, so we shall be able to introduce the vaccine, because the big milestone actually related to cold chain equipment so now have been solved, because we have now more than 300 new refrigerators actually to be distributed in different hospitals and health facilities, so that it can be easier also to solve the issue of cold chain equipment. And also we focusing much on also retraining actually health facilities and healthcare workers, because actually they have been using actually monodose hepatitis B, but those, and we are going to introduce actually the multi-dose vials, so 10 doses per vial, so that it can be easy also to understand that actually they need to switch. And we think that actually it would be very helpful actually to give this information, because we need also to focus actually on vaccine wastage. So this is very important, because actually we need also to explain very well actually the multi-dose vial policy, and ensure that actually we are vaccinating, yes, but also we are also limiting actually number of doses we are losing because of these 10 doses per vial. On our side, we appreciate a lot, and we thank our partners, Gavi, WHO, UNICEF, and also CHAI, most specifically country office, because actually they are very key. We can't do this alone, so with support from all those partners, actually, we shall be able to have a very good vaccination coverage with hepatitis B virus. Thank you. It's over. Thank you, Rachel.
Thank you so much, Hassan. Absolutely brilliant. We have overrun, but if people are able to stay for a bit longer, we can run this webinar on and take a few questions. So perhaps if I could ask our panelists to turn their cameras on, then if anybody's got a question and they'd like to speak, if you would like to put your hand up, then we can, I know Ben definitely can tell me who's got their hand up. But while we're waiting, I did notice that there was a question for Doreen. Are you still here, Doreen?
I am here.
Yeah, there's a question here. It says, did I hear correctly that Uganda uses TAF for treatment both for mothers and general population?
Yeah, TDF.
Yeah. Oh, TDF, not TAF. That's what it is then. It's TDF. Yeah.
TDF, yeah.
Okay. Has anyone got their hand up? Anyone would like to put their hand up?
Juliet, you can unmute your microphone.
Hello.
Hi, Juliet.
Hi.
You have a question?
My question goes to Michael Besong. Now, in this part of the world, I am from Nigeria, and our organization actually we target the hard to reach communities, remote communities. And over the years, we have found out that among these people, they hardly even get vaccination. And there is a big challenge amongst them. The rate of hepatocellular carcinoma, liver cancer the surge is there. People are dying. I can tell you that I know about 4 young people that have died in the last 2 years. These are the ones I know personally, young people, and it's becoming a big problem. Now, what do we do to cover these people, cover these communities, to make sure that they get vaccinated? And again, for vaccines that are distributed in local areas that do not have electricity, how are they going to be preserved? Or can we have access to vaccines that can be given that do not need to be preserved for a longer period under cold temperature and all that? So I don't know whether Michael will have something to say concerning this.
Michael?
So thank you for the question. So maybe speaking from the point of view of Gavi, all the countries that Gavi supports, Gavi provides some level of funding to for health system strengthening, which will go into cold chain and other activities that can help ensure that the vaccine actually reaches the last mile to the people who really need it. Now, for the specific case of hepatitis B birth dose and using it out of cold chain, it is known to be a very stable vaccine, and yeah, to be a very stable vaccine which can be used out of the cold chain. But I think there are still to be studies or structured studies to actually demonstrate the safety of this vaccine if it is used out of the traditional cold chain. But it's been proven to be a very safe vaccine. I don't know if I answered the question.
Yes,
correct.
you have. You have. Thank you very much.
Brilliant, thank you. Oh, there's another hand up here. Sadie? Have we got
Thank you for presentation. Thank you for letting me ask my question. Yeah, I am Saidi from Tanzania. My question is, we are dealing with the people who use and inject drugs. So I would like to know, the service you are talking about, what about the people who inject and use drugs, people who use drugs or people who inject drugs? What the benefit they got from the project you are talking about? So the question comes from the brother here and the lady, the first one from Nigeria. So I want to know the service for KP community, especially people who use and inject drugs, because they are the one who have this problem too. So that's my question. Back to you. Thanks.
Thank you. Does anybody, would anybody like to take that question? Funmi, maybe?
Thank you very much. And this is a very interesting question. Maybe just to flag two things. First, I think people who inject drugs are a very important group of people, and they do get pregnant and they do have children. So for sure, their babies should have the hepatitis B birth dose, since we're talking about birth dose within 24 hours of birth. So all of them attend antenatal clinic, and in the context of triple elimination, they will have hepatitis B birth dose. That's number one. The second thing is also to flag that hepatitis C is a major issue in people who inject drugs. And Rachel, I know you can speak to that. So I'll leave that to you. But one last thing I'd like to mention is when it comes to adult vaccination, this is different from hepatitis B birth dose. It is different from childhood vaccination, which Gavi would normally address. WHO has a recommendation for adult vaccination in high-risk populations. All right. So in people who inject drugs, after an initial screening test for identifying those who have hepatitis B, those should be referred to care because they may require treatment. For those who are negative, a course of hepatitis B vaccination may be particularly important, especially where they're in high prevalence areas and at risk of hepatitis B infection. I think I'll stop right there. So there are many options and various opportunities, and it will be good to see what services are provided to these people who inject drugs. In many communities, they have an integrated approach to people who inject drugs. They have the one-stop clinic where they do HIV screening, hepatitis B, hepatitis C clinics, harm reduction, and then they link them to care and follow up. I'll stop there.
Yeah.
I hope that was satisfactory. Okay.
Yeah, and I think you're absolutely right, Funmi. I mean, there are absolutely, it's different because, you know, we're talking about birth dose vaccine here, but definitely at-risk populations, they should be tested for hepatitis B. And if they haven't got it, they should be vaccinated because they are high risk, at-risk populations. Absolutely. There's a question here in the chat. I just wanted to pull it out from Bissy. It's to you, Michael, and it is: how may we enhance timely uptake of hepatitis B, BDV in rural communities? And I think this has come up a lot. I know you said that you've got this pilot and there'll be some, you know, you hopefully will have some data, but I think it's come up a lot in the chat and in other questions. So I wonder if you've got any thoughts.
Well, I mean, just...
Why are you giving me the floor? Oh, sorry. Sorry, I thought Rachel gave me the floor because
oh, well, no, Bissy, you can ask yourself.
Go ahead.
No, you go,
okay,
Bissy.
Thank you for the privilege. We've been doing a lot of work on the PMTCT in hepatitis, and we found that getting the timely uptake achieved is a real challenge, especially in rural and distal areas. And we did a bit of research on the timely uptake, how many babies that are born in any particular municipal get the vaccine within 24 hours, within 72 hours, within a week, and then within a month. And we found that there's very little knowledge. Some communities are using whistleblowers and so on. And I just want to know what Gavi is doing about improving the permeability of the vaccine, getting human drones. We actually found a community here in Nigeria that uses human drones and whistleblowers to get the vaccines to the babies. They take the vaccines to the babies as different from bringing the babies to the health system. So I just want to know if Gavi is doing anything about what we call the Coca-Cola logistics in healthcare, especially for the hepatitis B, birth dose vaccination, the uptake within 24 hours of the first dose. The remaining 3 doses are usually not a problem. Is that first dose, and it is so important in conferring immunity on the new baby. Thank you.
Okay. So from a Gavi perspective, like the Gavi program focuses primarily, not exclusively, but primarily on children born in health facility. So though Gavi is willing or will provide the vaccines for the whole country, so for all children born in the country, but for specific contexts where the vaccine will need to be taken to be certain hard to reach communities and all the necessary logistics that need to go into that, it will depend on the country's prioritization of their existing Gavi funding, because Gavi gives the country an envelope, and inside that envelope, they can do a range of activities from that. They could decide to focus on, you know, 0 dose in general, or specifically on hepatitis B, birth dose, outreach in hard-to-reach areas, polio, and other things. So depending on their prioritization, they might choose to focus on one program or the other. So, but Gavi gives general guidance on, you know, countries strengthening their community health platforms and seeing where they could leverage synergies to ensure that every child is able to receive the vaccine in a timely manner. But there is no specific support allocated for hepatitis B birth dose and for reaching children, for example, born out of health facilities. That will depend on how the country views that in the context of other priorities in the immunization program. That's from a Gavi perspective, of course.
Thank you, Michael. And Doreen, you've got your hand up. Did you want to make a comment as well?
Yes, I would want to add to what the last speaker said. I want to say that once we get the vaccine under Gavi, whether it is an adult vaccination, whether it is, but most of our vaccines for Gavi are under 5 vaccines. And therefore, in the package that Gavi gives for the vaccine, it doesn't streamline that this is basically working only on hepatitis. We have to move, we have to carry all the under 5 vaccines and advocate for all the vaccines. So when you go to the community, you're not only going to emphasize on the polio vaccine, you're not going to emphasize on only the TD vaccine, because Gavi has given us, the measurements are red categorization, reach every district, reach every child. So no matter the funds may not be level. It is just level at a program level. But when it comes to implementation, it cuts across all the vaccines. And therefore, any child born, whether in facility or without the facility, matters a lot. And Gavi is focusing on the 0-dose children, the missed opportunities that we have in the community. Those children that we don't reach in the community is what Gavi is looking for, so that we prevent all these preventable diseases to occur. So that is why we have funds for outreaches. We have funds that gives us the integrated child health days under Gavi. We have funds that support the 0-dose children under Gavi, no matter which source is coming from, whether under PATH, whether under CHI, where we are focusing on those children. So children born outside the facilities is still Gavi's mandate, is still our country's mandate. We have to reach them and reduce on the missed opportunities and the 0-dose children. Emphasis are put on the new vaccines because we want to measure them as equal as other vaccines. All the birth dose vaccines should have the same level. If polio 0 is at 90%, then even the 0-dose hepatitis should be at 95%. Because this is the same child, you're supposed to give all this antigen at one point. Thank you.
Thank you, Doreen. And we have actually just about run out of time. So Funmi, you've got your hand up. I'm going to leave you to not only your comment, but also your last, there's a comment in here around the amount of I can never say it, cancer among patients with chronic hepatitis. Urgent attention is needed. So I know you've got your hand up to answer, but I wonder, just as we end, whether you want to make a comment about that as well.
Right. Just to put a few comments forward, there's a lot to discuss. And I listened to our colleague from Uganda, and she's very correct. She's saying that oral polio, if it's at 90%, Hep B2 should be at 90%. And I think that is fantastic. But some of the logistical challenges is that oral polio is given orally and can be given by anybody, while hepatitis B vaccine is an injection. It's an intramuscular injection. And the mode of administration makes it a little bit more technical than a vaccine that is given orally. Of course, there are multiple challenges with health system, which is what Dr. Besong was trying to flag. So sometimes you can look at hepatitis B birth dose within 24 hours requires a strong health system, which is sometimes not forthcoming in Africa. I want to ask some of our colleagues a question. So what if a child comes to your facility after 3 or 4 days of birth? Will that child still be given the birth dose? That's a beautiful question. I'll leave it for you. But I think, yes, you should give, because WHO recommendations also provide options that if it's not within 24 hours, within the first 3 days is also a possibility. And very lastly, the whole essence of PMTCT, maternal testing, and tenofovir prophylaxis of mothers is another approach, which is also very pragmatic, because even these mothers in the villages, in the rural areas, they do go and get tested for HIV in pregnancy. So at that testing for HIV in pregnancy, if they have been tested positive for hepatitis B, then TDF prophylaxis can be used in that situation to bridge the gap between the birth dose, which may not be available. So there are multiple options. And of course, now there are innovations. We're looking at vaccine patches and various ways of reaching those hard-to-reach babies. So this is a continuing conversation, and I hope we'll have a part 2 and deal with challenges of birth dose. So the question was about how many of the babies born with Hep B have liver cancer? Was that the question?
No, it was just a comment about, it was from a public health virologist, and they say they organise health outreaches in remote communities. Right now, we have a lot of challenges with liver cancer among patients with chronic hepatitis. Urgent action is needed in these communities. I just thought, as we finish, I know that you have the WHO webinar coming up next week, and like the World Hepatitis Alliance, we are all really pushing for this integrated, joined up working treatment as harm prevention to liver cancer. So I didn't know whether you wanted a final word on that.
Yes, I would be excited to give a final word. And I think I must say that hepatitis B treatment and care is liver cancer prevention. So in response to the question, if you do go out and do an outreach and you test 1,000 persons and 10 are positive, your work is not done until you link those 10 positive hepatitis B surface antigen patients to care. They must be linked to care because that is what you will contribute to liver cancer prevention. And with the new WHO guidelines, it is so much easier to apply a public health approach to identifying who to treat and who not to treat. That is a huge step forward. As we are today, any part of the world, if you have liver cancer, that is tertiary care, and those patients need to go to care. The cost of care is humongous. Cancer care in Africa is really difficult, and oftentimes, which is very sad, these are youngish people, between 40, 50, 55 years, in the best time of their life. And that is what we're preventing by looking at liver cancer, by looking at hepatitis B birth dose, the hepatitis B vaccination, the PMTCT, the testing and the care of hepatitis to prevent liver cancer. I'll stop there, but please join us next week, Monday, as we talk more about how do we prevent liver cancer using hepatitis elimination. So thank you, and over, I'll put the flyer in the chat for those who are interested. Thank you, and back to you, Rachel.
Thank you so much, Funmi. Perfect way to end. So I want to say thank you to all our presenters today. Such an important webinar. I'm sure we could run it on again. This happened at the last webinar, but we don't have any more time today. So I just want to say thank you very much to everybody. We do have a little survey if you have time. I think the link has been put in the chat. If you could please respond, that would be fantastic. But I wish you all a wonderful evening, morning, whatever time of day it is for you. And thank you so much for joining us yet again for our Let's Break It Down webinar. Thank you. Bye-bye.